I hope you enjoyed your lunch. I know I did and had some great conversations with a few of you. I'm really still looking forward to our afternoon session today after just a very, very provocative and stimulating set of talks this morning. It's with great pleasure that I introduce the moderator for our next session called Supporting Communities. Anita Stalinga is the Vice President of Corporate Communications and Public Policy and Corporate Secretary of the United Way Greater Toronto. She has over 30 years of experience in the nonprofit sector and currently leads a dynamic team to drive long-term change and improve social conditions in the Greater Toronto area. Please join me in welcoming Anita and the panel. Thank you.
Thank you so much, Daniel. I've always wanted to teach, but unfortunately it didn't work out, so this is the closest I get. Thank you for inviting me, and it's my true honor and privilege to be moderating our panel today, Supporting Communities. And it's so appropriate because at United Way, our mission is to meet urgent basic needs and to improve social conditions for people in our community. And we do that through our research work in partnership with academia, with our focus on policy and bringing solutions, and investing in a network of agencies, 300 community service agencies across Peel, Toronto, and York region. And our focus is on poverty, with the intersection of poverty with housing stability, financial stability, engaged and connected residents, and a strong community services sector. So to be moderating this panel of distinguished leaders in this space is a dream. So please let us welcome. We have, and you have the bios of everyone in your booklet, so I won't read them in detail, but we have Luke Shaefer, who's going to be presenting to us, as you can see on screen, on the topic of protecting the health of children with child cash transfers with evidence from around the world and the States. And we have Arjumand Siddiqi, who is going to be talking about what does the social and spatial distribution of disadvantage tell us about social policy. And last but not least, we have Michael Stepner, who is going to be talking about our safety net and understanding the breadth of how social policy shapes risk and security. So please join me in welcoming our wonderful speakers. And those who are here can join me perhaps at the front of it, or not yet, or as they're presenting. Till after Luke is done. Okay, great, wonderful. Luke, welcome and thank you for joining us.
Thank you. It's great to be with you. And I wish I could have been there in person. I very much wanted to be, but was unable to get up to Toronto. So hopefully I'll get an invitation another time. And thanks especially to Daniel for inviting me, whose work I've followed for a long time, from way back to work on employment policy between Seattle and Vancouver that I always found very novel and incredibly useful into my work on low-wage work many years ago. So I believe some of the things that you talked about may have touched. I imagine that you've heard a bit today about the expanded child tax credit. And I'm going to hit on that a little bit today, too, and tell you about some work that I'm doing in Flint, Michigan, as well. But I happen to be on sabbatical this year, working on this project, ARG's Kids in Flint, I'm going to tell you about, but also trying to travel the world a bit and get more of a global perspective on policies to impact child poverty in particular, and thinking about child well-being across the world. And I think sometimes we sit in circles and we think about like what are if only we knew what to do, or if only there was sort of a roadmap on what to do, if only there was like tried and true policies. And one of the things that I've been struck in this global perspective as I've done my own work on child cash allowances, particularly in the United States, is how this is sort of one space where that's exactly what we have. So there are, let's see, I'm trying to advance the slides. There we go. Actually, more than 140 countries, so that's over 70% that have adopted large-scale government-funded child cash transfer programs. So these are programs that usually start from the logic that raising kids is expensive and society has a reason to come alongside families in that work. So these programs can be found in every region of the world. There are high-income countries that more often adopt universal or near universal programs that cover virtually all children, usually all except the most affluent. Lower income countries more often impose like a means test, and so they'll only cover lower income kids or some sort of conditions. But, you know, when you see something that's happened in 70% of countries, right, this isn't sort of a policy that we have to wonder about because it's really been tried over and over again. Sometimes with social policies, we have randomized controlled trials, and that provides a lot of really useful information. But there's lots of reason why something might or might not work in a randomized controlled trial. That are different from why it might work out when it's adopted by a nation state. And so I think we're always left wondering whether or not sort of this social science laboratory of an RCT is going to translate to something bigger, or there's lots of reasons why some of the effects of something like a cash transfer would be lost in an RCT. For example, all of the ripple effects, the spillover effects of everyone in a community getting it rather than just a random group. So we really just have a tremendous amount of evidence to make decisions based on child cash transfer programs and their effectiveness. Just to sort of start out, UNICEF has done an analysis of universal and near universal programs using the Luxembourg income study and finds that they reduce child poverty by 5 percentage points, that they're the sort of the biggest impact in reducing child poverty. Of any sort of social programs, and that's why they call child cash benefits the foundational policy for child development. So studies from lower income nations find that child cash benefits are linked not only to reduced poverty, but also to improved access to healthcare, better nutrition, increased vaccination rates. And I think an important element of this is that these worldwide studies find that child cash benefits act as a complement and can support rather than substitute for other public health and social services. So cash benefits can be actually, especially from this evidence from lower income nations, can be more effective when done in complement with public health and social services, as can these other sort of public health and social services be more effective when they're done in conjunction with a cash transfer. A holistic study looking across many different lower income nations find significantly improved young child mortality. And then studies in higher income nations, including Canada, find child cash benefits, of course, linked to reduced poverty, improved food security, decreased aggressive behavior among children, improved mental health, improved educational outcomes, and particularly investments in children. It's also from this body of literature that we have studies that find that by providing an unconditional cash transfer, a study from the Canadian program in particular, we can either have no impact on substance use or actually reduced substance use. And so the theory of that are twofold. One is that by providing more resources, we may reduce stress on families, and so they're less likely to turn to substances. Another theory, though, is actually gets to the social meaning of the money, where providing a child cash benefit may possibly have a different sort of set of impacts than just a regular UBI, or sort of a complementary set of impacts of being money with a particular social meaning, that when that money hits the bank account and says child benefit, it reminds people of the jobs that they care most about, and so which is being parents. And so it sort of has a priming effect and may lead to some of the reduced substance use that we see. The United States, of course, for a brief moment in time, joined other peer nations with a near universal child cash benefit through the expanded child tax credit. I know Chris was presenting earlier. I don't know if he's in the room, but of course, Chris and his colleagues at Columbia were central to all of this, have been an incredible leaders to the nation and offering estimates of what sort of the anti-poverty impacts of these programs are, and also in sort of envisioning how they might fit into the safety net that we have. So in 2021 in the United States, we sort of followed what has been happening in Canada for some time through a longer period of having a child cash benefit and more recently having increased that. In the United States, we had $250 per child per month, $300 per young child for nearly all children, just sort of leaving out those at the very top of the economic ladder. And of course, we, just like Canada before us and just like the UK before us, we know thanks to Jane Waldvogel's work, and just like every other country that's done this, right, time and time again, replication after replication, we saw child poverty plummet, hit historic lows in the United States. We saw increased spending on food, housing, and child enrichment, again in line with research from other nations and with what we would have expected from evaluation of other income support programs in the United States. Reduced food insecurity and food insufficiency, reduced material hardship, and improved financial stability. We now have, I think, half a dozen papers that link the expanded child tax credit to improved mental health of parents, and a paper that finds reduced incidence of child abuse cases in emergency departments. So of course, the program was not renewed. So for that brief shining moment, we said, hey, we're going to join our other high income peers. And then we saw what was possible, and we decided to go back to where we were. And you can see that in this chart. So this is, you might have seen a version of this in Chris's presentation, where, after the year 2000, we were pretty much stalled out, according to the supplemental poverty measure, on any poverty declines. But the economy started to speed up a little bit in 2019, and then we lost 20 million jobs, but thanks to a whole set of income supports in the United States, and particularly the expanded child tax credit in 2021, we saw child poverty hit the lowest level recorded. That went away, and we saw child poverty increase, the highest sort of one-year increase that we'd ever seen. There's a similar story about food insecurity. I think one of the interesting things you can see, this is plotting food insecurity among households with children from 2001 to, I think, 2023. And you can see it really sort of follows the business cycle. So 2008, that was our last big recession. But then when COVID hit and we lost 20 million jobs, the federal government really responded. And particularly for families with children in 2021, and we hit the all-time lowest level of household food insecurity in 2021. And again, it spiked back up again after that. So we really we don't have to guess with this policy anymore. Like, there are going to be times when findings come and go, but maybe it has this impact here, maybe it doesn't. But consistently across nations, across time, we see the same type of effects over and over again. So I was despondent, of course, when the expanded child tax credit in the United States wasn't renewed, and sort of wondering what to do and how to keep policies like this in the public imagination. And luckily for me and my at least professional well-being in terms of doing things I cared about, was invited to be a part of a program in the city of Flint, which we call a citywide cash prescription program for pregnant moms and babies. So this is a program called RX Kids, and it provides a child cash benefit to pregnant persons during the last part of pregnancy, and then throughout the very first year of life. And we'll talk a little bit about the details, but why focus on that very first year of life? Well, in the United States, we see, and again, Chris and his colleagues were important contributors to this literature, that families are poorest in the United States right around the birth of a child. And this is part of the logic, I think, of more generous paid family leave policies, that, in the United States, we see income really start to drop in the months right before birth. It sort of troughs right around the time of a birth and then slowly starts to rise, but remains below its sort of preconception level even after 12 months after a baby's been born. So combine this with the fact that we know more and more about how incredibly consequential from a development perspective this period is, right? And there's just a lot of reason if we're going to provide income support during any window of time, I think the combined sort of fact that families are poorest right around the birth of a child and the development needs are so critical suggests that we should do it during this window. Another reason is because in the United States, child welfare is actually, child welfare cases are highest during that first year as well. So you can see the fraction of families who lose a child to the child welfare system into an out-of-home placement is more than double during that first year of life any other year in the across ages up to 18. And there is quite a significant body of research that finds that income supports broadly, right, food assistance in the United States, fundable tax credits, all have like a really consistent impact in reducing child welfare involvement among families. So RX Kids was evidence-based, but also community-driven. So parents and partners plan for over a year. Mom consultants, and this was, I think, both a matter of bringing a program to the city with the highest child poverty rate in the United States. And also, we talk a lot about narrative change, and this has been a project about narrative change where Flint now has become one of the leaders to the nation in having a program like this that covers all families in the city. So it follows sort of the UNICEF guidance of being a universal and unconditional program. We think of it as a targeted universalist approach. It's a place-based approach that every family in the city of Flint, it's not a pilot. We're not talking about 100 or 30 families. Everybody in the city of Flint is eligible, no matter your income. But of course, the profile of people who get it is exceptionally poor because it's a very poor place. So it's sort of by having a place-based, targeted universalist approach, we can sort of have our cake and eat it too by getting rid of all the stigma involved with means tests and also still serving a really, really poor group. It's a gift and not income, so it doesn't impact any of the potpourri of public benefits that we have in the United States. And it's cheap. We were able to access TANF funds through a sort of a wonky provision called non-recurrent short-term benefits. So TANF is a federal block grant that flows to states to provide help to needy families, but has really been absconded with by most states to fill budget holes because of the flexibility of the block grant. Talk about sort of a lesson that we've learned over and over again is that block grants, the flexibility of block grants make it difficult to actually meet policy goals. So as I mentioned, that very first payment in RX Kids is a $1,500 payment after 20 weeks of gestation. TANF government funding sort of covers those green boxes of that first $1,500 payment and then $500 a month for 3 months for lower income families. And then in the United States, we sprinkle on top of that philanthropic dollars and take $500 a month to age 1. So the program helps families for the end of pregnancy and then through age 1. It's a partnership with Michigan State University, University of Michigan, and Give Directly, which is nice because it means we don't really have to do any of the hard work. Give Directly is an international leader in providing cash transfers to families. So as I mentioned, this is about cash transfers, but it's also about reimagining things, right? This is a program that it doesn't start from the logic that you're poor, that you can't handle your business, that you're probably trying to cheat the system, and so we're gonna make you jump through all these hoops. Rather, it starts from a logic that this is how we're supposed to care for each other. Raising kids is hard for everyone. And this is a society that trusts you to make your own decisions. we really reinforced themes of dignity, of love, of respect, of value, and celebrating the joys of moms and babies. So I got to participate in the first Flint baby parade, which involved hundreds of babies and a marching band and ice cream and cotton candy and all sorts of things. Just very quickly, a couple of our early findings. One, I think, really striking thing is that when we compare the families that are enrolled to RX Kids to publicly available vital record stats in the United States, we know a lot about who's been born in a place. We see that in a very short amount of time, we're able to hit well over a 90%, even to 100% take-up rate. And of course, sort of month-to-month numbers jumble, and that's why you see sort of 103 versus 92 between months as like things are getting registered from month to month. But I think an incredible, we in the United States talk a lot about how it's impossible to find these hard-to-serve families, and you have to do all these things to reach them with programs. Nobody signs up for programs. And so in the city that has huge distrust of outsiders, in a city that has a high child poverty rate, we were able to get pretty much everyone in a matter of just a couple of months. Nearly 70% of our respondents make less than $10,000 a year, and I think that sort of speaks to the benefits of a targeted universalist approach, at least in the United States. People report that they spend the money on baby supplies, food, rent, utilities, transportation. I think very much in line with a lot of the analysis we saw with the child tax credit. And then here's where, things start to get, I think, really interesting. We see families saying that it's really helped improve their ability to access healthcare, improve the health of themselves and their infants. And, it's interesting to wonder whether or not a name like RX Kids, is there this priming effect where like when we do an unconditional benefit, is what we say about it really matter in terms of how it's perceived? We have put a survey in the field of families, really moms who had a baby in Flint in 2024 and thus had access to RX Kids versus 2023 when they didn't, compared to non-Flint folks who were born at the same hospital. So Hurley Medical Center, I think, accounts for something like 80% of the births in the surrounding region. And so this gave us sort of a nice difference in differences type framework where we could see differences between families in 2023 in Flint compared to 2024 when they had access, and compared to the difference between families in these 2 years in the surrounding region. And what we saw across the board with our material hardship questions, every single material hardship question that we asked was positively signed. So we see that Flint 2024 births improve compared to 2023 births, and the differences in comparison to non-Flint residents. So this is that sort of difference in differences impact. The biggest ones was around rent and mortgage being up to date. Like we see a really big impact there. Families saying they have the freedom to choose how they spend their money, and that they're able to get the kinds of foods that they want on a regular basis. And this, of course, again, sort of this next slide is about questions of feeling respected, feeling valued, and a question about depression. When we look at the families who had access to RX Kids in 2024, in this difference and differences framework, we see a huge reduction in not reporting sort of on an accepted scale, high depressive symptoms, and a huge increase in families in Flint reporting they feel respected, valued, that they have hope, and that they feel loved. So much so that families in Flint in 2023 were below on all of these questions, families in the surrounding area. And in 2024, they're actually on par or are more likely to say that they feel respected, valued, hope, and loved. In the next little bit, we're going to have evidence from vital records analysis, again, in a difference and differences framework. At the moment, it looks like we're seeing increases in prenatal care and a reduction in inadequate prenatal care, increased diagnosis of gestational diabetes, reduced smoking in the third trimester. That increase in diagnosis of gestational diabetes actually brings Flint more in line with the rest of the state. So it suggests more care gets you more diagnosis and reduce very low birth weights. So, of course, it's wonderful to have all of this new evidence, and we're going to have papers that are coming out over and over again. But I think when you put it in the global perspective, right, it's fascinating to think about what seems novel and new in the United States, that this is the first time anyone's done this in the city. But here is a policy, right, in a framework, even during unstable times and uncertain times, that has been proven to work over and over again across the world. And once again, we see it work here. So we can sort of stop being surprised, and I think about what would this look like, rolled out in the United States, but also maybe this is something we can think more about as a global community somehow in the future. Thank you.
Good afternoon, everyone. It's such a pleasure to be here. Also want to thank Dan. And I was also struck by your Seattle, Vancouver work years ago and became a fan then. So I will try to expedite things. I thought I would kind of take the perspective of the epidemiologist I am and tell you a little bit about what I think health trends can tell us about social policy. This is just a sort of orientation slide. So people in my field do work like this, which is to take a look at how social policies affect health, similar to what we just heard. This is a study we did some time ago where we looked at changes to the welfare system in the United States, the mid-1990s welfare reform that was enacted by Bill Clinton. And on the right is a graph using that same difference in differences perspective to figure out when that policy changed and there were fewer benefits available, there were sort of more restrictions to get welfare, there was a sort of heightened restriction on eligibility, what happened in this case to single moms. And you don't have to pay too much attention to the difference between the triangles and the squares. It's just sort of sister methods. But the punchline is that in every case, from safe drinking to smoking to days of mental health, all sorts of healthcare measures, single moms who access welfare looked worse after welfare reform was implemented. And more generally, it's not a surprise that this is the case. This is a World Health Organization conceptual framework that kind of tells us how and why social policy relates to health and why it's in particular so important. And basically, if you start on the far left with societal conditions, including social policies, the issue is that those are really the fundamental drivers of so many social processes and biological processes and behavioral processes that affect our health. So social policies affect our socioeconomic status, which affects how much access we have to housing security, food security, how much stress we experience. Social policies, independent of that, may give off signals, as Dr. Shaefer mentioned, may have sort of narrative. I'm looking at Carolyn Tui, narrative effects psychologically about our worth, and that can affect health. But the key is that social policies are not just a determinant of health, but we think they are one of the most fundamental drivers of all the other determinants, and that's why they matter so much. So I wanted to talk a little bit about COVID-19 in Toronto and a little bit about what the insights from COVID might tell us about social policy. So this is the kind of map you would routinely see in Toronto during the COVID era that highlights the number of cases or the rate of cases in different neighborhoods, with the darker colors indicating higher case rates. And the bands essentially that you see, whereby there's darker neighborhoods on the outer 2/3 and lighter shading in the middle, kind of correspond to a bunch of social and economic characteristics of Toronto neighborhoods. So on the far left, those bands correspond to the percentage of Black and Brown Torontonians, so that there are higher percentages of Black and Brown people in those outer 2/3 compared to that middle third. It also corresponds to income, lower income groups in the outer 2/3 compared to the middle third. And so the question kind of was, why this patterning? This is effectively the stuff that epidemiologists do, is figure out why this patterning is occurring. And early on, if you watch the news during COVID, you would see, before we knew how it spread, before we had sort of pattern data, you would see many reports like this, where there was a report about a personal support worker, a caregiver of some form, usually at that point from a nursing home, who had died of COVID. And indeed, in the end, from science from a number of physician scientists, epidemiologists, what we discovered is that the reason for the racial and the income patterning during COVID is because race and income map onto essential caregiver work. And so the more essential caregivers in a neighborhood, the higher proportion of, essential workers, the higher the proportion of COVID, because while the rest of us were home, those were the people who had to go out and expose themselves. Working backwards, they are clustered by neighborhood because of their income and also arguably because of their race. So there's two ways to think about why that spatial distribution happened and what we might do about it. And one is that you could think of this as a true place-based phenomenon. So there was an airborne infectious disease. It circulated in neighborhoods that have higher density, where people, again, who are at higher risk are concentrated. And therefore, it makes a lot of sense, especially in the case of immediate infection control, to focus on place-based solutions, which we did. There was some effort to do a better vaccine rollout than they had done initially when they did not account for place. So they started pumping up the way that vaccines were being administered and access to vaccines after they figured out that actually there's a neighborhood distribution of risk, and so on and so forth. You can imagine a variety of place-based initiatives that would make sense given this kind of picture. On the other hand, the fundamental drivers of this place-based distribution don't solely reflect place. So one question we might ask is, why were more Black and Brown and poorer people in essential service jobs in the first place? Why are they clustered, segregated by neighborhood? And these are questions that, of course, predate COVID. So when you're in the thick of COVID, place-based policies make a lot of sense. But if we were to think about what the fundamental drivers are, they are much more structural than place. In fact, if we take place as a given, we're almost forgetting the big part of the story, which certainly didn't start during COVID. Let me give you another way to think about this. The top is the patterning of COVID. On the right side is the patterning of, on the left side is the patterning of diabetes, and on the right is the patterning of blood pressure. And of course, there you go. Same patterns emerging for outcome after outcome after outcome. Why? Because social policies and social conditions drive almost everything in health. They are where the action is. So, this is just sort of initial thought more than anything, but I'm wondering if place analyses provide more immediate solutions, more sort of critical solutions in the interim, but that when we find spatial patterns, it really behooves us to think about the sort of broader policy context as well. I'll leave it at that. Thanks.
Wonderful. Well, let me not be the only one to neglect Daniel. And thank you, Daniel, for inviting all of us. It's really an honor as an economist, as a young professor, to share my work with such a broad audience with such varied interests. And so in an act of optimism, I'm going to try to share 3 projects that I'm working on with you in 15 minutes. And the theme of this, the question I'm posing is, where is our safety net? And the recurring theme that I'm going to try to come back to is to encourage people to think more broadly about the effects of each program they're studying, because each act of public policy tends to affect the humans involved in more ways than the policymaker, the designer, the person writing the legislation anticipates. So just to set the groundwork, I'm coming from a perspective that providing social insurance is one of the major functions of government. There's an American who said that it's useful to think about modern governments as a big insurance plan with a military attached to them. And when we're thinking about the types of things we need insurance against, 2 big ones, perhaps the biggest sources of income risk for working age households, are layoffs and illness. And both of those cause long-term losses in financial security. We've seen this across countries, across time periods, for layoffs and for illnesses. And those income risks are partially insured by social insurance programs. So earnings losses post-layoffs are lasting more than 10 years. EI benefits in Canada can last up to 1 year. Many people who are rejected from disability insurance have pretty low work capacity and quite poor health. And I want to layer on top of this the observation that economic and health risks are bidirectional. And that's something touched upon by Luke and by Arjumand, that not only is developing an illness one of the largest risks that humans face, but we're developing illnesses. We're all vulnerable to illness. Half of Americans are developing a new chronic health condition in their 50s, regardless of whether they have prior chronic health conditions. And this health is highly unequal across groups and across geographic areas. Rich Americans, rich Canadians live much longer than poor Canadians. Life expectancy is varying substantially across local areas. So I'm going to present 3 papers on this theme, that social policy is hiding in more nooks and crannies than we might expect. And the first is going to be about the insurance value of redistributive taxes and transfers, looking at how large the economic risks from layoffs and illnesses are, how well those are insured by the full Canadian tax and transfer system, and what the sources of those of that insurance is. The second thing I'm going to present upon is how post-secondary education is affecting earnings, disability, and longevity during someone's life. And I'm going to be using variation from the United States that was affecting 1 in 8 college and university students in the US who lost access to very substantial subsidies for higher education in 1982. And we're going to use that to look at this broad-based near universal program to ask what were the causal effects of going to higher education on later life outcomes. The final paper I want to share with you in brief is about the growing class gaps and shrinking race gaps in life expectancy in the US from 2001 to 2019. Because during that period, I think these results surprised us as co-authors when we first saw these results. This is work in progress. The gaps in life expectancy between rich and poor are growing dramatically. Perhaps that's not surprising to the people in this room. But the gaps in life expectancy between Black and white Americans are shrinking dramatically. And I'm going to show those trends to you and use those trends to study some of the mechanisms that are underlying those changes in health disparities. So let's start with the first paper in this whirlwind tour, talking about the insurance value of redistributive taxes and transfers. And it's nice that in this room, we have such a large delegation from ESDC here in Canada, who really manage and run the most important social insurance programs. And my hope is that next year, maybe you'll invite your friends and colleagues from Finance Canada, because the message here is that the work they do is about as important for social insurance and social policy as the work happening in ESDC. So how could that be the case? Well, how do governments insure people against income shocks? Well, it starts with formal insurance programs, the type of things with insurance in the name. We have employment insurance, we have disability insurance, and those are providing a little bit of insurance for extensive margin losses. People who are out of work, who have recently experienced a layoff or a serious illness, can receive some replacement of their formal earnings. There's no insurance for intensive margin losses. That is, if you are no longer able to earn as much as you used to, but you have returned to work following a layoff, following a disability, typically these programs provide nothing. At the same time, we also have a whole redistributive tax and transfer system that is insuring income risk. So redistribution is transferring not just the way that we typically think we're transferring from rich people to poor people. Redistribution transfers from the good years to the bad years of a person's life. And if you want to read the highly technical papers of economists who are characterizing the mathematically optimal income tax system, it's going to depend, the optimal amount of progressivity depends on the amount of income risk we face, because progressivity helps ensure that risk. So I posed 3 research questions that I'm going to study with Canadian data. The first is, how well are working age households insured? Second is, what are the sources of insurance? And finally, what is the insurance value of the full tax and transfer system against these major risks that we face in working ages? And so let's start with just one example. I'm going to look at many cohorts who experience layoffs, many cohorts who experience hospitalizations. I think it's easiest to think about one cohort, a group of people who were laid off in 2010. And we can look back 13 years using the data, and I'm going to look ahead 5 years. We can see that I'm going to match people to similar people 3 years prior to the layoff. And during the 10 years prior to that, they were all on very similar trajectories. And then if we follow them ahead, well, things start to, if you're at a company that's about to do a large layoff, your income growth tends to tail off a little bit in the year or 2 prior. And then what we can see in the subsequent 5 years is that there's a large loss in income and only a very partial recovery. So that's 2010. Let's now broaden our perspective to look at all of the people who were laid off in any year between 2003 and 2010. We've got a bunch of cohorts. I've shown them in dark gray. They're all kind of overlapping. So for the most part, I'm going to pool them. And what we can see is that if we look 13 years back, all of these people who are laid off are looking similar to the folks I'm going to compare them to. And then if we look ahead up to 12 years, there's an incomplete recovery and no sign that there's going to be a return to the former trajectory of earnings. Those who are laid off have a permanent loss in income. So what catches them when they fall? Well, to start with, what's the magnitude we're talking about? Well, average household income is declining 14% before taxes and transfers. And here in Canada, social insurance is going to shrink the share of income lost following a layoff by 40%. And a little bit of that is going to come from employment insurance, particularly in the first year that you're laid off. That's the period in which employment insurance is designed to protect your income. And it's doing a good job at that. Of course, people who are laid off or falling off the job ladder, they're more likely to be laid off in the future than the average person. And so they're still receiving a little bit more employment insurance 5 years later, even 10 years later. But the bulk of the insurance, more than 50% of the insurance that they get, is coming from other transfer programs, things that are not conditioned on whether they were recently laid off. And then the final sliver is coming from progressive taxes, that when their income falls, they're paying less in taxes. So this is just the average person. But of course, we're interested not just in what happens when you average out every person who is laid off. These risks might differ a lot at the bottom versus the top of the income distribution. So if we look and we split Canadians into 10 groups, the 10 deciles, based on their household income 3 years prior to a layoff, we can see, perhaps unsurprisingly, that the income risks from layoffs are concentrated at lower income levels. And even after the work of employment insurance, you can still see this large tilt where low-income Canadians are facing more risk from layoffs. They're going to lose more on average following a layoff than higher-income Canadians. Now, if we look at the operation of the full tax and transfer system, it looks completely flat. Thanks to the progressive tax and transfer system, all Canadians in a post-tax and transfer basis are facing the same percentage risk from a layoff. On average, they're losing 13% of their income from being laid off, as opposed to this steep line varying between 30% and 18%. All right, going to do a quick whirlwind tour through hospitalizations. The story is very similar. So like a layoff, a hospitalization event, a serious illness, leads to an average income loss that persists. There's no sign of recovery over the subsequent 12 years, on average, of course, right? Some people are trending down, individuals are trending up. Social insurance is once again shrinking the share of income lost by 60%. You might have thought that here, disability insurance is a long-term form of insurance, unlike employment insurance, which is short-term. So disability insurance would surely be the bulk of it. And it's not. It's important, and it is important over the long term. But once again, more than 50% of the insurance people are receiving is from transfers that are not conditional on the fact that they got sick. It's from the broader safety net that our system provides. And if anything, the progressivity is much starker when it comes to health risks than employment risks. So if we look at the income risks from hospitalizations, they're dramatically concentrated at low incomes. This is both because people are getting sick with different illnesses and because of the nature of work. So there are many things underlying this figure that I'm showing you. Disability insurance has very little progressivity. Here we're talking about CPP disability, we're talking about short-term EI sickness benefits. Much of the insurance, in fact, virtually all of the progressivity is coming from the broader set of taxes and transfers. So if we then plug all of this into a bunch of formulas and we ask, like, what is the annual value that people are getting from the tax and transfer system? Like, if you had to convert that into an insurance premium and you said, hey, I'm going to sell you some insurance against the income risks you face from getting laid off, getting hospitalized, what would people be willing to pay for the insurance that we're already providing? And here in Canada, it's about $500 to $1,000 a year is the value of that insurance plan. It is progressive, so it's higher at low income levels than at high income levels. But I will note that at every single income level, even for the richest Canadians, the progressive tax and transfer system is providing them with security, with protection against the risks that they face. And more protection is coming from progressive taxes and transfers than from EI and DI. So that's a starting point. Let's transition quickly to these second two papers will be briefer in my overview. But here's some very early work on how post-secondary education is affecting earnings, disability, and longevity. And the starting place is that, look, the correlation is unambiguous. We know that compared to high school graduates, whether you're looking in America or in Canada or in Europe, people with a college or university degree have higher lifetime earnings, they have lower lifetime incidence of disability, they live longer lives. And the natural question is, well, how much of that is due to education and how much of that is due to the fact that richer people, people with higher income, more educated parents are the ones who are going to university? And to answer that question, really the ideal natural experiment would be something that generates variation along a policy relevant margin. So a lot of this research is going to be looking at the effect of a compulsory 12th year of education. That's where you'll see most of these estimates right now. And that's great, like forcing everyone or a compulsory education till age 16 rather than 15. That work is done, right? That's not the policy relevant margin when Canadian policymakers are debating how to increase education for Canadians. We want something that is affecting a large and representative sample of students. So if it's two means tested, then we're getting a very narrow average treatment effect. We want to know how is education affecting the broad population. And we want to understand a recent, but perhaps not too recent cohort, because we want to study their lifetime outcomes. And really, I think that the Social Security Student Benefit Program in the US is an ideal natural experiment. It was ended in 1982. It was providing average benefits that were 3.5 times higher than the cost of tuition and fees at a 4-year flagship public university. So this was a program that 1 in 8 American college and university students were receiving that was providing them a full ride through school. Why were they getting that ride? It was because they had a parent who was retired, disabled, or deceased. The modal person here had a deceased father. And so because of their circumstances, they were able to go to post-secondary education essentially for free. And in 1982, Congress decided this is way too expensive. Let's not do this anymore. And the program ended at the end of high school rather than at age 22 or the end of post-secondary. So what did that do? Well, the program accomplished the cost savings that Congress wanted, where far fewer people, the number of people receiving these benefits at age 20 went to 0. And here I will only have the preliminary results on earnings. So what did this do to people's earnings? And in this figure, I'm going to show you the reference group who graduated high school in 1982. And I'm going to look at the cohorts before that who received these benefits and the average earnings of the subsequent cohort who did not receive these benefits. So if we look at just the adjacent cohorts, you can see average earnings were a little bit higher for the cohort that had access to these benefits. If you go back, program was phased out. So if you go back to the group that had full access, their earnings were higher. Now, there are a lot of things changing about higher education in this period. You have these are groups that are affected by the GI Bill and the Vietnam War and the expansion of education to more people. So we really need a control group. So we're going to look at people who didn't have a deceased, retired, or disabled parent as a reference group. And what we can see is that the reference group was completely flat. There was no difference in the reference group in their average earnings. And so we can, comparing these two in a difference in difference type analysis, we can see this large effect in the ballpark of what we might expect, about a 10% increase in earnings from each additional year of higher education. The results on longevity are so recent that I don't yet have a figure disclosed from the RDCs. So let me just give you a rough sense of the magnitudes. So Americans with some college education, about 6 percentage points more likely to survive to at least age 55 than those without any college education. And from our looking at this quasi-experiment, the people who were induced to go to college as a result of this program, about 50% of that gap appears to be a causal effect of education, with the remainder is likely being a difference in the average person who chooses to go to college and their characteristics prior to that. So let me conclude now with a brief examination of these growing and shrinking gaps in longevity. So the context here is that if you look in 2001, there are large gaps, about a 5-year gap between an American at the 25th versus the 75th percentile of the income distribution, a 4.6-year gap between the average Black and the average white American in terms of how many years they can expect to live in their lifetime. These are huge. So to put them in context, the CDC estimates that if we were to eliminate all cancer deaths, if we were to cure cancer, life expectancy would go up by 3 years. The effect of the COVID-19 pandemic at the depth of that pandemic was a 2.7-year reduction in period life expectancy. So both curing cancer and the worst days of COVID were both smaller in their effect on longevity than being Black rather than white in America, or being in the 25th versus the 75th income percentile. Now, skipping all of the data work, the methods, let me tell you the results of our analysis. So if we look in 2001, we see this 4.7-year gap. And you can attribute about 3.2 of those years are associated with, or descriptively associated with, the differences in income between the Black and white populations of the United States. 1.5 years are even looking at, if you think taking an average American or a random American who is Black versus white with the same income, you would expect on average a 1.5-year gap in life expectancy in 2001. Now by 2019, the gap in life expectancy between two people, one Black, one white, with different incomes, with the same income, they had no gap in life expectancy. Two people with the same income, different race, had the same average life expectancy. The remaining gap, there's still an enormous gap, it's all associated with differences in income. Well, at the same time, the gaps in life expectancy between lower and higher income Americans are growing, as rich Americans lead longer lives while lower income Americans lead shorter lives. Now, based on conversations with others, based on also the presentations here, there are a few causes that come to mind, and I want to tell you the causes of these trends are much broader than one might expect. So if we decompose, what are the sources? What are the causes of death associated with these trends? Well, cancer is a big one. Cardiovascular disease is a big one. HIV is incredibly important. The advent of antiretrovirals was extremely looms large in the data at reducing the gap in life expectancy between Black and white Americans. COPD looms large in the class gaps. And deaths of despair, which I think consume a lot of our attention, they're present, they are important. They're about 10%. They're on the order of 10% of this trend. And if you add up every single other cause of death, you get about 1/3 to 40%. So we started using these individual causes of death to try to understand the mechanisms. And I'm summarizing a bunch of work when I say that these growing class gaps and shrinking black-white race gaps are driven by, look, a combination of factors across multiple diseases. But one thing that comes out clearly is that changes in the incidence of disease and upstream risk factors are playing a large role. And those are things that are likely associated with broader social determinants, the kind of mapping that Arjumand shared in her presentation. And so reducing disparities in life expectancy by income is central, both in its own right. Rich people do not deserve by virtue of their wealth to live longer than anyone else, but also potentially to help further narrow racial gaps in longevity. And so focusing on these socioeconomic disparities is important to address broader disparities going forward. So let me conclude there by saying that I hope what you take away from this is that no matter what the policy it is that you are studying as an individual, what policy you're working on designing as an individual, I hope that you're thinking broadly about the potential effects of that policy, how it can affect, if you're focused on income, how it can affect health, how education can affect health and income, because ultimately our safety net comes from many different places. And public policy broadly is essential for shaping the risk and security that we feel in society. So thank you very much.
Thank you. Yes, Arjumand and Michael, please join us here. And we also have Luke. I think you could have had a whole day on each of these topics. Honestly, this was incredibly thought-provoking and insightful information and approaches, and would love to have an opportunity to dive deeper. But here we are today, and there's an opportunity for us to ask a few questions. Maybe I'll get us started with the first question, and then we'll look to the audience for some questions from you for the three of our speakers here. So we've heard a variety of different approaches: universal, place-based, the link to inequities of all kinds, race, income inequalities, life expectancy, and so on. Where do we focus? There's certainly an appetite for us to bring solutions forward, but there's also an appetite to do things quickly, to demonstrate the success of programs. And sometimes we know the kinds of things that work, as we've seen the evidence, but somehow the will, whether it's a political will or a community will, isn't there. And so how do we bring this forward? And what are the kinds of things that we should be focusing on from a policy perspective to really improve people's lives, to improve these conditions that we're looking at? Would love to hear your perspectives on that.
I'm happy to go first. And perhaps I'm pandering to the audience, but I'd say one of the things that is essential is actually measuring the things we have already done, having the data that's accessible to researchers in the universities, to journalists, those that are left in the profession. But having that data made available, I think, as Luke points out, there's a lot of stuff that we know works. There's also a lot of stuff that we have done and failed to study, failed to measure. And so I think broadly, data access is essential for identifying the policy that can guide us forward. That's perhaps the longer term point of view, and you were asking short versus long term. I'll cede the floor to my colleagues who might have thoughts on that.
Yeah, maybe I'll just add one thing that I sort of struggle with, which is the extent to which single policies tell enough of a story. And I think Michael's presentation alluded a lot to that. And I sort of worry sometimes about our ability to capture policy complexity by the methods that we routinely kind of go to capture very precise estimates for particular policies. And I think it ties back in large part to Luke's point about sort of the imaginary as well. So as much as policies change and shrink in their generosity and eligibility and so on, we start to lose perspective oftentimes on how many different things matter, what the potential is for policies. And so all of that sort of complexity, I think it's important to capture somehow. Luke, maybe I'll pass the mic to you.
Yeah, I think both of those are really, really good points. Here's my view on sort of policy construction. I tend to think that bigger tents are better. I think I had always thought that there was animosity among people sort of just above the eligibility threshold in the United States. You know, people who are 180% of poverty being, you know, sort of having animosity for the fact that somebody at 130 or below gets food assistance and they don't, even though they're really struggling. And during the pandemic, when we took a very different approach and policies were much more popular, I really came to believe that. So wherever you put those lines, you both like make some people who don't care, but also a lot more people who think, why am I not getting helped? And so I happen to think that it always depends on what you're doing, but simpler policies are usually better, policies that people can understand, tying them to the values that people have. So, you know, people have huge like education values, right? So if you can create policies that tap into those, I think they can be more popular and stable. But you want people to be able to understand. In the United States, our biggest problem with higher education, I think, and we have many, is that how much higher education costs in the United States is a complete mystery to everyone. And, you know, we get to engage in like massive price discrimination. And so we put millions of young people and their parents through this like tumultuous year. And, you know, in the end, they're probably going to get financial aid and it's not going to be as bad. And like sometimes because we do that, people go away from the places that they think are going to be really expensive and they go to lower tier places and they actually get a worse deal, right? So when we have complicated policies that are hard to sort out, people get confused, it creates animosity. So all other things being equal, simpler policies with a bigger tent that people can understand and that tie directly into values are sort of some of the principles that I would build policies on. But a second piece of that is I do think that there are certain places that deserve more treatment. Obviously, there are certain groups of people in the United States that deserve better treatment. But we, from a government standpoint, we have significant constitutional challenges. And actually, I don't know the answer to this in Canada of like, can we deliver a benefit to, say, Black Americans where there's more than enough reason to justify something? But constitutionally, because of equal protection, we can't deliver that. But could we deliver those types of programs for poor communities that are just because of segregation are actually disproportionately made up of people of color? So that's kind of, you know, with our kids, that's sort of the mold is like we took one that's a simple policy that's based on values that covers everyone, but targets a poor community. And it can have, you know, a bit of a reparative side to it because you can definitely target a community in the United States. A lot of stuff that we do that's place-based in the United States is not remotely effective, and it helps people up at the very top, like of those, you know, the people that have the fiefdoms in the low-income communities. So I think more programs, if you're going to target a place, that actually get down to the people, you know, to lower income people in those communities are better.
Thank you. Arjumand, I wonder if you have a perspective on place-based policies, as we saw that incredible data, and we've seen that in so many instances, whether it's COVID or low income, income inequality, where people live matters. And what are your thoughts on place-based policies and what we have to think about?
Yeah, I think there is kind of two ways to think about this. One is that there are sort of particular kinds of place-based policies that probably make a lot of sense, implementing community level services, having community-driven sort of resources and maybe having federal funding or provincial funding, but being able to execute in ways that really resonate for local communities and places make a lot of sense. My larger concern is that when we talk about the kinds of policies that Luke mentioned, that Michael mentioned, policies around insurance, income, as you say, income inequality, a lot of sort of fundamental issues around inequality are driven by policies that occur at a higher level and aren't really reducible to the place. And so I think it's a sort of not either or, but an and. And I think one without the other really would be insufficient.
Mhm. Did you have?
Sure.
Yeah.
Yeah, I would add, I think there's a lot of value to place-based policies, and I want to highlight two challenges to place-based policies. The first being that local governments tend to be very cash constrained, and in particular, lower income communities tend to have more financially constrained city and local governments. And so the sorts of services that are provided in downtown Toronto or in New York City tend to differ from the sorts of services that are provided in small communities in Ontario or small communities in Michigan, like Flint, because of the income of the government involved. Say a second challenge, and we see this a lot in Canada, is the jurisdictional challenges, where many of the things that, as Arjumand noted, things like income policy, these sorts of supports, here in Canada, local governments are entirely they're fictions of the provinces, right? And provincial policy supersedes local policies, and so it's very difficult to imagine. There's a sense of like local knows best, and people in their community might know what they need, but be unable through the democratic process to say interest a provincial or federal government in the needs of their local community. And many of these policies are being determined at provincial or federal levels.
Yeah, very interesting, actually. Very, very insightful, because our work is so local when we think about neighborhoods and places. Questions from the audience? Yes, I'll go to you first, and then I'll go to you.
Thanks. Just following up on exactly on this conversation, and completely agree in Canada, and I think, Luke, you kind of alluded to this in the US as well. In the US, it's the Constitution. Canada, here we don't talk about the Constitution as much. We just say jurisdictional responsibility. So this is our code word for it's not your area. But if I look at some recent federal social policy, even some economic policy movements that are getting at some of this place-based need, or the reality of the difference of place-based and how that works. And I don't know that we do it well. And it's actually a question seeking advice and help, if not like immediately now, but thinking about upcoming work that we can do. So for example, early learning and childcare, I'm not going to claim particularly in Ontario or Toronto, that Canada-wide was a resounding massive success. But one of the things you'll notice if you read the action plans provinces put in place in order to receive the funding is an emphasis on analysis, but where there were childcare deserts, communities where there wasn't already childcare in place, in part because parents economically were of lower income and unable to afford it, or because they were in urban centers that were high rent districts, so less opportunity there for a provider to open a childcare, or in rural and remote communities. And the federal government pushed hard to have the provinces consider place-based demographic information to be able to prioritize new childcare centers in those very areas where there were none. I don't know that we do it well, but I'm interested to know really what we're missing in some of the theories and methodologies, the data we should be looking at to push on that even harder going forward.
Luke, do you want to take?
Yeah, I mean, that all sounded good to me, I have to say. So I think using a data-driven approach is really good if you're going to allocate resources. And I should have been, I think, more specific when I said place-based often doesn't work. I was referring to, in particular, like economic development type policies that are meant to sort of reduce poverty. Just they don't trickle down, and so I didn't mean that in terms of like place-based health centers. So I think there's been a move. A lot of us in the federal government have been trying to do more to just use a series of metrics that are well collected across communities to make decisions about where to place things, rather than to leave it up to sort of political exigencies. And it sounded like from your question that was some of what was happening. And I think that's a really useful approach. And I think it's great to use data, because sometimes the data actually do reveal things about communities that we didn't realize were true. So we can realize, like, it's interesting to me, there's some places that are known for being low income and having, some of the other things that places often use are just health outcomes, right? So you could actually create a lovely, like, useful index that's looking at poverty rates by some level of geography, as well as life expectancy or infant outcomes. I know in the United States, these are all like publicly available things, and then rank communities on that continuum. You could talk about, like, the center's got to go in a place between these bands and that sort of stuff. I guess another question to consider is, will whatever it is be successful there? And what else do we need to do to try to make it successful? So a big challenge we have is we have exceptionally poor rural areas in the United States, and I think Canada does too. But we often don't have the workforce to deliver things in rural communities, or it's difficult to sort of find the scale. So that's another thing that has to be addressed. It's actually a benefit of cash transfers, is that they can be delivered in rural communities nearly as effectively now as urban communities. So the last thing I'll mention, the Canadian child benefit, it's actually got sort of targeted universalism in that you get more if you're lower income. Pretty much everybody gets, phases out at the very top, but you get the most if your income is low, and then you get even more if you have young kids. It's interesting to think whether or not, like, should there be a supplement for living in a poor place? In the United States, you could make the case that, like, for everything we know about the geography of mobility, that we should be doing cash transfers disproportionately in lower income places too. So I think just being creative and being data driven are some of our keys to these difficult questions.
Michael or Arjumand, did you have anything to add to that?
I would add briefly that I think your question highlighted the complexity of this type of policymaking. So if the goal is to make sure that every parent receives X dollars during the first year of their child's life, that is something that is very easy for the federal government or a provincial government to design and ensure. If the goal is to ensure that everyone has access to a daycare spot in their local community within a X minute walk from their home, that is something that the federal government would have a very difficult time organizing. Even a provincial government would have a very difficult time organizing. And so I think the complexity there highlights both the challenge, but also I think there's a tendency to look at to try to solve the problems that are easier to solve. And so the idea that every parent needs to have access to daycare, affordable daycare, but also just that supply is a problem and not just the ability to pay, is a much more difficult problem to solve, although they're problems that are sort of equally easy to state. And I think that affects what kinds of policies we see and what problems we see left unaddressed.
Arjumand, anything to add? No? Okay, thank you. There was a question over here. Yes. There's a mic coming.
Hi, my name is Amalie Baird. I'm a consultant in the social impact space, and I've lived most of my adult life outside of Canada in Latin America. I had a question for Luke. In particular, in Latin America, I've seen a number of sort of social policies where the child benefits go specifically to mothers versus fathers, and even more specifically to single mothers, for example. And I was wondering if you've tracked any of that and have any comparative data, wondering whether in the US you're seeing whether the money's going into the man's bank account, the woman's bank account, a shared account, and whether that's even relevant in the US as it might be in some other countries.
Yeah, I would say that it's not completely locked down empirically, but I think that the evidence on the whole points to the idea that on average, women and mothers will be better stewards of cash transfers, or particularly good stewards of cash transfers, that the money is more likely to be spent on the child. And, you know, again, these are just averages. So there's lots of dads that will spend the money in the right, you know, on child enrichment and sort of household expenses. But I think the totality of the evidence suggests that it's better to send it to the mother, or it's a better bet, if you will. There is also, you know, questions about domestic violence. So that's actually one of there's also some literature out there that finds that cash transfers can be associated with sort of a spike in like domestic violence, because it's a resource to fight over, I guess. And so that it's a little bit of a question of it's just like shifts the timing of when that was going to happen anyways. But we sort of designed our program with these things in mind, that you really, the two things you have to do, if you want to call them conditions, are you have to, for our kids, is prove pregnancy and then prove childbirth. And moms are going to be the best equipped to especially do the first one, and probably do the second one on average. And so they would control enrollment, and then they get the choice to either send it to a bank account or to get the money on a reloadable debit card, which they have to pick up. And so I think our position has been to sort of give moms the empowerment to decide, this is something that's going to go into a bank account that I share with the spouse, or is going to go into my own bank account, or is going to go into a reloadable debit card that they don't even need to know about. So it's sort of an added source of money. Now, you know, these are all averages. And so there are circumstances in any sort of policy framework where mom is behaving, you know, in ways where maybe she loses custody, or maybe dad has custody. And so you do, you know, when you sort of privilege on the averages, it does create these circumstances where you're just like, it's more likely that there's going to be a dad who really is the primary caretaker who has difficulty, you know, accessing the benefit. And so that's a downside, but, you know, there are pathways in order to move that. And so, yeah, again, it's not like these things are not locked down, but I think the evidence really points in the direction. And so, you know, I think policy makers have to decide if they're going to take it to account or not. I get the last thing I'll say, in the United States, we did see, like with the economic impact payments, we did see like small spikes in like opioid overdoses when those big checks went out to everyone. We don't really see it with like the expanded child tax credit. That was a smaller amount of money sent to sort of families with children for an express purpose. And you can see that in the literature too, I think, where when the money does go to single moms, you don't see sort of the same sort of communities having more people in the ER. And I think it reinforces the sort of the better bet in the aggregate type finding.
Thank you for the question. There was a hand up over there. Did you still have a question? Yeah, go ahead.
Thank you for your insights. So assuming a finite budget, how do governments decide between a more economically efficient cash transfers, which individuals can spend according to their utility function, or broad-based social assistance services or infrastructure? And finally, how much of it should be left to the private sector, say private insurance or private childcare? Thanks.
Happy to take a stab at this.
Great.
And I think what we have to keep in mind is that these decisions are made through a political process, not by a scheming economist in an academic department or in a treasury or finance department. And so when it comes to, say, child cash transfers, there was an explicit decision made, I think it was a political decision made in the United States to try to make it as broad-based as possible under the theory that that would result in it being extended. And it's hard to imagine how it was surprising to me, and it's hard to imagine how that policy could have been changed to make it more likely to have been extended, but it was not extended, despite popularity, despite being broad-based. And so I think usually the relevant constraints that matter for efficiency versus equity here are probably coming through the political process more than the models that an economist or the social planner, as you might say in an economic class, might write down. I don't think that's actually how these policies get made or designed. And sometimes even then, the results of that policymaking process might surprise us, where policies that are popular don't get extended, policies that are broad-based and equitable, like the Affordable Care Act in the United States, might be extremely unpopular for many years. I think that political process is something that, fortunately, I'm not accountable for in my line of work, but is incredibly difficult to thread that needle.
Anyone else want to take a shot at that question?
I think
Just-
the point, go ahead, please.
No, I was just going to say amen. That's it. That's all I have.
I thought, yeah, those were very astutely put. I am for cash transfers when there is more of a sustainable funding source. So I think I'm less game to like give everybody $1,000 one time based on some work that I've done, work some other people have done. I'm not totally opposed to it, but I think if you have a finite amount of money, I actually think it's worth considering like infrastructure improvements. Maybe that's to homes. So lead abatement is sort of one of those things where we often don't have enough money. But you can make a one-time investment and you can impact not just sort of the health of the child in the home, but the next child and the next child and the next child. Or, we helped design with Mayor Duggan and his team in Detroit, program using American Rescue dollars I think we replaced a couple thousand roofs in the city. And so whatever that is, right, whatever you can do, I think if you have a finite amount of money for a finite amount of time, it's worth thinking about like, what is it, like a capital investment of some sort that I can make that will have a ripple effect over time.
Arjumand, go ahead.
Yeah, I just wanted to add one thing that I thought about in terms of the political framing and the media framing. So in Ontario, many of you know, there was scheduled to be a universal basic income pilot that was canceled. And if you look at the sort of discourse around that basic income pilot, it was essentially saying, look, this is a much better situation than means tested social insurance, social assistance, which is incredibly onerous. It has all these, eligibility issues, et cetera, et cetera. And this is this kind of almost stupendous opportunity to do this really big, great thing for low income people. But as one of my doctoral students, former doctoral students pointed out to me, the amount that was being proposed for universal basic income was less than people received for social assistance adjusted for inflation in the mid 1990s prior to cutbacks. So, you sort of wonder exactly how we are framing what is possible, what budget constraints are, and sort of how we conceptualize how we make decisions.
Well, here in Ontario, we have one form of universal basic income, and it's $200 checks before provincial elections.
At least I heard, at least 200. Daniel, do we have time? I know we've gone over. We should head for a break. I'm sorry, we have gone over in this session. Thank you so much to the brilliant 3 panelists today. Thank you for the incredibly important and impactful research that you're doing. And there's no doubt there is a real thirst and a hunger for these kinds of discussions and deep dives. So keep it going. Thank you to the Munk School and Daniel and team for all the wonderful work in putting this on. Take care, everyone.
Thank you.
Thanks so much.